morning. My name is Lynette Martins, and I'm here with Scott Schweikart. Our topic today is health justice and equity. It is the second part of our public health law series that we began with Professor Lindsay Wiley. The COVID-19 pandemic has revealed and deepened existing racial inequities. It has further exacerbated the disproportionate impact of existing health inequities on historically marginalized populations, both long-term and short-term. For racial and ethnic minorities, disparities in exposure, susceptibility, and treatment are not unique to this pandemic, but are further complicated by the urgency of an infectious disease and the lack of adequate resources and support for public health interventions. Many thanks to those of you who have provided questions for this seminar. This session will be very conversational, so you are encouraged to use the Q&A tool throughout this discussion, and we will try to get through your questions as we proceed. We are delighted to have such an esteemed panel to share their insights into this important topic. We have Professor Rakaya Yerby. She is a professor of law at St. Louis University School of Law and the co-founder and executive director of the Institute for Healing Justice and Equity, St. Louis University. Professor Yerby is a specialist in racial disparities in healthcare, the political economy of healthcare, and social justice in medical research. She has dedicated her career to improving the lives of vulnerable populations by addressing the lack of equal access to quality healthcare. Professor Seema Mohapatra is a tenured associate professor of law at Indiana University School of Law. She received her law degree from Northwestern University and a Master of Public Health from Yale University School of Public Health. Her research interests include the intersection of biosciences and the law, assisted reproduction and surrogacy, international family and health law, healthcare disparities in the United States, and informed consent. Professor Ross Silverman is a professor of health policy and management at the Indiana University School of Public Health and holds a secondary appointment as professor of public health law at the Indiana University McKinney School. His research interests include legal, ethical, and policy issues in public health and medicine, mobile health law and policy, interdisciplinary curriculum development, professional school admissions, medical humanities, human rights, and patient safety. Welcome to all of you. Many thanks for being here. Let me begin with a fundamental question for Professor Yerby. This question is regarding the construct of race. Is the use of race becoming an outmoded distinction in looking at health disparities, in the sense that race implies a biological basis for differences? Isn't race more of a function of culture and ancestry than simply biology?
Thank you for that question and having me be a part of this podcast. So yes, race has been outdated for a while in terms of trying to connect it with health disparities. Really, it is more about structural inequality, which is not equal to categories of race or class or gender. Really, when what we're talking about, particularly in COVID-19, is about hierarchy and about power and lack of access to needed resources. Furthermore, even when we use race to say that it is a proxy for culture or ancestry, that is not a good proxy either, because it denotes that somehow Blacks or Latinos or whites are a monolithic group and they act in this particular way. And so when we look at COVID-19, when we look at health disparities generally, it's more about either lack of access to health care, lack of access to paid sick leave, lack of access to treatment or testing, or even lack of access to clean water. And that is not connected with race. It's more about poverty and structural inequality.
Yes, Professor Yerby, we see that COVID-19 is disproportionately impacting the poor communities and communities of color. In your co-authored article, Law of Structural Racism and the COVID-19 Pandemic, you provide several examples to illustrate this point. Is this something new?
So no, when we actually take a look at even some of the information that HHS published around the 2009 H1N1 pandemic, they noted that Native Americans, Latinos, poor African Americans all suffered disproportionately from infection and death. Why? Again, not because of race, but more because of their failure to be able to stay home, because a majority of these individuals are essential workers. They're not provided with paid sick leave, so they have to continue to go to work even when they are sick. They are in housing that doesn't have access to water, and usually they lack access to health care. And so when we look at what happened all the way back to the 1918 flu, we see disproportionate impact on communities who are poor. We also see that in 2009 H1N1, where studies were shown, again, linking it to lack of access to paid sick leave, access to health care. And so when we move forward to COVID, this is just a continuation. And hopefully, as Professor Mohapatra and I wrote, that we need to make some changes, structural changes, to provide people with paid sick leave, access to healthcare testing, and that will make the change. I just want to highlight one thing. What would be nice too is a shift in how we actually track infections and deaths. We do it based on race. We're not doing a good job tracking it to actual risk factors, like, are you an essential worker? Do you have paid sick leave? Do you have running water? That is something that we can address. And if we track that, then we know then we need to pass policies that address those structural issues instead of just looking at race.
Excellent, thank you. Professor Mohapatra, I want to ask a quick question about COVID-19 just in general is likely to be with us for some time, given no effective real treatments and no vaccine on the horizon. We know that it has already impacted historically marginalized populations. What will be the short-term and long-term impacts of COVID-19, for example, on racial and ethnic minorities, other communities such as immigrants, women's, especially women of color, the elderly, disabled, and also poor communities?
Yeah, thanks so much for having me here today. As you mentioned in your introduction, the communities that you've mentioned, the marginalized communities, are already being disproportionately affected by the pandemic. And these communities were already being shortchanged pre-COVID. And so when you add a pandemic to it, Robert Wood Johnson Foundation has defined health equity as meaning that everyone has a fair and equal opportunity to be as healthy as possible. And so to achieve that, you really need to have obstacles to health like the ones that Professor Yerby talked about, such as poverty, discrimination and their consequences, and access to fair pay, quality education, safe environments, and healthcare to be removed. What we've seen during this pandemic, and what we probably will continue to see, is that these groups are just having worse access to the healthcare, worse access to quality jobs where they would have the ability to work from home, housing where they would have the ability to shelter in place with, people that are ethnic. I'll give you an example. People that are ethnic and racial minorities are much more likely to live in substandard housing or housing with multifamily units. It's very hard to socially distance if you have been exposed to the virus. You're more likely to be working in jobs where you are going to have access or be exposed to the virus. And so those structural issues of where people work, where people live, what kind of access to healthcare and testing they have are going to continue to be a problem throughout this pandemic. And so the financial impacts of COVID are being felt by everybody, but the people that are feeling it worse are those that are already poor, those that are already have housing insecurity, have healthcare insecurity. When we have employment tied to your healthcare and we have record unemployment, you're more likely to lose employment, and so then lose your access to healthcare as a result. And so some of those short-term impacts that we're going to feel are those financial impacts and impacts to access of healthcare. And the thing is that some of those groups that you've mentioned, like people with disabilities, elderly populations, are more likely to have comorbidities that would make COVID infection more serious and have more serious complications. So in the short term, we're going to see increased hospitalizations, increased deaths in these populations. And so we are already seeing this, and unfortunately, we're not doing much to stem this kind of trend right now in terms of increased testing, increased contact tracing, increased isolation. And so we really need to make sure that we're focusing on these public health principles that we all know in light of these populations that are being affected. And so, in the infectious nature of COVID-19, we're really seeing how everyone is interconnected, and it doesn't really matter if you think that you are completely free from these problems of poverty or problems in housing. Because our communities are interconnected, it's really in everyone's best interest to make sure these communities are protected. And we want to make sure that immigrants, particularly unauthorized immigrants, don't have a chilling effect and worry about ICE enforcement or public charge group that they're actually going to seek healthcare services. I could go on a long time about that answer, but we really need to focus on these populations because that's going to, focusing on the people that are most vulnerable and most marginalized will ensure better health for everybody.
Thank you. Professor Mohapatra, I have another question here.
Sure.
In your co-authored Health Affairs blog entitled Structural Discrimination in COVID-19 Workplace Protections, you say that these disparities are caused by structural discrimination. Can you address what this is and how it impacts social determinants of health?
Sure. And so Professor Yerby and I have written a few co-authored pieces, and in each of them, we have focused on structural discrimination as a key part of this inquiry. And what we mean by structural discrimination is the ways that laws and policies are used to limit access to resources such as safe housing, quality healthcare, and high-wage jobs. And so we already know that prior to the pandemic, people of color, racial and ethnic minorities, particularly women of color, already disproportionately suffered from poor health outcomes due to structural discrimination. But what we're seeing in this pandemic is that in each of these areas, and we've looked at it through employment, through housing, and through healthcare, we see that the lack of protections in the laws and policies are really affecting people's health. And so we really need to focus on ensuring that employment laws, housing laws, and health laws are expanded to protect these populations. And so I'll give you an example of housing. And so I already mentioned that racial minorities are more likely to be living in substandard housing, which are also tied to higher rates of cardiovascular disease, tied to living in food deserts, and that's also tied to higher rates of cardiovascular disease and respiratory infection, which kind of full circle also are risk factors for more serious COVID-19 infection. And so the CDC has said that people of color are more likely to live in densely packed areas, multi-generational housing situations. And so those are, if you are in an apartment where you have to go in an elevator or you're forced to interact with others, if you're relying on public transportation, there are lots of areas where you are more likely to also be exposed to the infection and then less likely to be able to isolate from these infection. In terms of healthcare, we have many areas in the United States, especially ones that have high populations of racial and ethnic minorities, have had public healthcare facilities closed. And so, especially in the beginning of this pandemic, when there was much more limited testing, we saw that in areas where there were more racial and ethnic minorities, you were less likely to get access to testing because of the closure of these facilities in these high minority populations. And also because of our biased healthcare delivery system, minorities that were coming in, especially Black Americans that were coming in, there were a lot of anecdotal stories about people that were being turned away either because their symptoms were not being taken seriously, who later on got very sick and died of COVID infection, or that they didn't have a primary care physician, which you needed to have in order to get referrals for tests. And so we this is another way that kind of the healthcare system itself has been a problem. When we've talked about undocumented or unauthorized immigrants, most of whom are racial and ethnic minorities, they don't have access to healthcare through the Affordable Care Act exchanges. And because of punitive immigration policies, there's a real concern that people are not either getting the food that they need, that they're not getting the help that they need because they're worried about their immigration status. And so if these populations are sicker, that is also going to affect anyone that they interact with as well. And so I think that probably Professor Yerby is going to talk about employment a little bit later, so I'm not going to go into that. But there's a lot of things that we have kind of highlighted because these are areas where these are structural problems. And so these are not quick fix answers that we can say, okay, well, we're going to do X and it's going to happen. We really need to begin with the structures that are affecting the poor health and making these populations more susceptible to COVID infection and lack of treatment.
Perfect, thank you. One of the areas that that's largely impacted by COVID-19 is employment. And you just raised that area just now, Professor Mohapatra. I'd like to open that up to Professor Yerby. Layered on top is the concept of an essential worker and what positions are actually considered essential. How does employment impact these disparities that you have noticed in exposure, susceptibility, and treatment?
Right, so when we look at employment, part of the issue is that a majority of the essential workers are women and people of color. And that's across all areas, not just in low-wage jobs, but also in high-wage jobs. When you look at those who are essential workers, the two biggest areas are in healthcare and in food production. And so we see that those are predominantly filled by minorities and women of color. And so they have to continue to work. And so what we see, just using meat processing workers as one example, they're often forced to continue to go in. They're not provided with protective gear. Again, they don't have paid sick leave. And with the executive order that Trump did back in late May, actually late April, you saw that they had to continue to work because we were worried about our food production. And so you see these places that are already harmful and dangerous, people already suffering injury, in addition, in agricultural workers in terms of mold, in terms of lung, respiratory conditions. And so that increases your risk for COVID-19. It increases your exposure because we're forcing you to continue to work in these areas. You don't have paid sick leave. And we see continuing reports about how testing is not available to these workers, particularly farm workers and meat processing workers. It's not clear because the testing information is not being made available either to the public or even to the health department. And one particular you see in North Carolina recently where Latinos were being turned away. Latino farm workers were being turned away from getting testing because they didn't have the necessary papers, which contradicts the CDC's recommendation and contradicts what they're trying to do to provide testing. So then these workers know you are either asymptomatic or symptomatic, you have a COVID-19 infection, so do not go to work. And so to me, these are examples of structural problems that increase the exposure, susceptibility, and lack of treatment, which then disproportionately harms women, people of color who are disproportionately essential workers.
Thank you, Professor Yerby. I have another question here. There seems to be strong support in favor of profit growth at any expense. This pandemic has made that clear. Can you discuss this prioritizing of profit growth over health?
Yes, and I think going back to the executive order about the food production is a perfect example. We get to the point in mid-April where lots of meat processing facilities are having outbreaks and are needing to shut down. And lots of the companies began to argue that there was going to be a meat shortage. And so that was the basis for the executive order to keep these plants open and to also set in motion the ability to keep open farms to be able to address this issue. But what we saw after the executive order, well, actually in the executive order, that there was no requirement that the meat that was being produced would be used in the U.S. And so we see that lots of meat was being exported to China, and actually they have set a 20-year record for exporting meat during this time. And so I think that really begins to show sort of this profit motive over health. The CDC, a month after the executive order was issued a report showing who was actually infected and deaths in meat processing for 23 states. And what we saw that the rates quadrupled. So in 1 month after the executive order, we had the rates quadruple in terms of infections and deaths. And of those states that reported racial data, we see that 56% of the infections were in Latinos. And so that's what we see, but then what happens is it's not just the workers that are impacted, right? So the workers get infected, they go back and infect their families, and they impact their entire community. So going back to what Professor Malhotra said is that we tend to think about it only in terms of the one individual that's infected, but it impacts all of our communities. And so when we think about trying to keep things open, or even trying to open schools or other places, we just need to make sure that we are balancing both the benefit and the risk.
Great. Thank you, Professor Yerby. Professor Malhotra, I think Lynette just dropped off there, so I'm just going to go to her question here. We have this, oh wait, let's see, I think she's back. Okay, Lynette, can you hear us? Lynette? Hello? I don't think she can. Can you hear us?
Yes.
It wouldn't be a Zoom session without technical difficulties. So.
Lynette, we're up to your question next now.
Sure. We are interested in, we've discussed some of the inequities that have led to racial and ethnic disparities in health. Recently, some of the legislative efforts of this administration have passed, for instance, the CARES Act in response to the COVID-19 pandemic. Professor Malhotra, can you discuss some of the impact of this CARES Act and address any gaps in its initiatives?
Yeah, sure. So, I mean, the CARES Act it's the largest economic relief bill in U.S. history. And so it has done a lot to help businesses and individuals that are affected by the pandemic, but there were quite a few blind spots in the CARES Act. And so some of the blind spots that Professor Yerby and I have kind of identified are the fact that the workers that are covered under the CARES Act that are being provided with either increased compensation or sick leave, often a lot of low-wage workers are not included in those definitions, either because they are not considered employees, they're independent contractors. Also, there are certain whole categories of workers that are not covered under the CARES Act, such as agricultural workers. And so there have been certain and undocumented or unauthorized immigrants are not covered. And so there are certain groups of people that have just not been covered. And also when we think about what the CARES Act did, the CARES Act did provide Medicaid coverage for COVID COVID-19 related testing and treatment. But even though states can use their waivers to increase who is covered by Medicaid, it did not actually tie in and require any states to do that. And so we have groups of people, unauthorized immigrants and people that don't qualify for Medicaid, that are still not able to afford care, that are left out of that. CARES is a wide-ranging act. Some of the things that it did was establish a federal 120-day moratorium on rent evictions, but that has now expired. And so there are things that need to be done in order to make sure that people that have lost jobs, people that can't afford their housing, that they can stay in their housing, because that's all related. That's a public health measure related to their health care. And so, in terms of things that should be covered in any future legislation, whether it is the HEROES Act that has been passed by the House, not really the Senate, the act that was just yesterday discussed, that has a lot of gaps in it. But, we really need to think about the fact that people that are essential workers should be focused upon, because if we're saying that somebody's essential or a critical infrastructure worker, like the meat processing workers that Professor Yerby talked about, we really need to make sure that if they are having to work, that they are being paid hazard pay, that they have access to sick leave, and not just in name only, that they're actually getting that kind of sick leave, that there is childcare available for them. This is another collateral consequence of the pandemic, is that poverty leads to people having their children taken away, and especially people of color. And so we really need to make sure that we're not setting people up in positions where they don't have childcare, where they have to work, and they're put in these untenable positions of having to take care of their children, and the schools are closed and childcare is closed. And so even though there were childcare subsidies in CARES, they were not specific to essential workers. And so if they're kind of available to all, it is not clear that the essential workers are getting the care that they need. And so kind of focusing on those populations as well, and then making sure that all workers, whether they're employees or independent contractors, regardless of immigration status, if they're workers that are being exposed, we should make sure that we're protecting them in terms of testing, in terms of hazard pay, in terms of sick leave.
Thank you. I have another question for you. With no national strategy in place, states are left in the lurch. That is one of the broad failures of the public health response, but there have been others. Can you address these gaps in the public health response to COVID-19?
Yeah, so in general, in March, when everything started in the US, we really, when states started to shut down, the real thought, public health wise, is that this would allow time for states and for the federal government to get access to more